Hi, today we're going to be discussing the Ebola virus. Hi, so my name is Chelsea Sherman, and I'm going to be talking a bit about the origin of Ebola virus. So, the first outbreak of the Ebola virus was in 1976, and there were actually two consecutive outbreaks. The first one being in the Democratic Republic of Congo by the Ebola River, and the second one being in South Sudan. Initially, they thought that the two outbreaks were connected. So they thought that someone from the Democratic of Republic of Congo traveled to South Sudan and then infected people there, but that was not actually the case. After research, they later found out that the two outbreaks were independent of each other, so meaning that they weren't actually related. Um, they found this out because the strand of Ebola virus found in the Democratic Republic was the Zaire Ebola virus, and then the strand found in South Sudan was the Sudan Ebola virus. They determined that they were um, genetically different. Um, Also, through research, what we have so far, they do believe that the reservoir host of Ebola virus is the African fruit bat. And by reservoir host, they mean so the origin um, of the virus. They believe that that is the African fruit bat. And the way that this transmitted into humans was from bush meat consumption. So that means humans eating African fruit bats as well as other animals that may be infected with the Ebola virus. And the outbreak of Ebola that most of us are more familiar with is the outbreak between 2013 through 2014.
Transmission of the Ebola virus. The Ebola virus can be transmitted to people from wild animals such as apes and monkeys, and can spread through the human population by human-to-human contact, just like any other virus or disease. Ebola can be spread by direct contact with infected blood, usually by blood transfusions, as well as other body fluids that came from a person who was showing symptoms of the virus or someone who had recently died due to Ebola. Bodily fluids that are known carriers of the virus are usually found in diarrhea, urine, breast milk, sweat, and semen and vomit. Ebola can be spread through the handling and consumption of wild animal meat or hunted animals that have already been infected with the virus. And if a human consumes the meat from the infected animal, then they too can end up infected with the virus.
The development of government surveillance for Ebola was a little bit more challenging than usual due to the limited public health infrastructure in the countries Ebola was more common in. The CDC faced a very overwhelmingly hard task by doing so. There was a lack of trained staff, limited technology resources, as well as limited telephone and internet service. On top of this, many people were reluctant to report cases and to report people that they were familiar with, who were friends with, who were carrying this. The CDC was able to implement a case based surveillance system, conducting case investigation and reporting, as well as contact tracing. These two surveillance methods alone were the primary components, but there were more mild components such as community event based surveillance. Effective case reporting was extremely important, requiring timely collection as well as reporting. This data did help response staff to be able to understand the impact Ebola had at the time, providing better efforts on how to target this outbreak. While on the other side, with contact tracing allowed rapid identification of new cases, improving clinical outcomes and helping to reduce the transmission. Um, this then helped a lot of other ministries of health to manage the epidemic, strengthening epidemiologic and data management in the affected countries.
When looking at the medical surveillance and response for the 1976 Ebola virus outbreak, the first patient, also known as Patient Zero, was seen at the Yambuka Mission Hospital. Immediately following the discovery that the patient had Ebola virus, the hospital was shut down as a midwife nun had also tested positive for the virus. International notification and specimen provision occurred within 5 weeks of the onset of the first case. The entire surrounding area and villages were put on quarantine, and then those suspected of being ill were to seek isolation shelter in huts away from the villages. Outside health officials were brought in for support because they only had a small group of nurses and they had no doctors on staff. They only had an assistant paramedic. The international committees worked with local nurses to create screenings to rule out potential infections, and they went village by village, door by door to make sure that everybody was quarantining and to rule out any type of possible Ebola virus infection. And care at these hospitals were only given to those who were acutely ill and showing life-threatening symptoms. If they weren't showing life-threatening symptoms, then they were sent home with medications and to rest and to isolate. The medical surveillance continues to go on even to today. There still is cases of Ebola virus outbreaks since 1976, and there is even an outbreak currently.